Good afternoon, everyone. I'm Dr. Ray Foxworth, president of Chiro Health USA, the network that works for chiropractic. And for those of you that don't know about us, where have you been, brother? uh, I'm having a conversation today with my dear friend, Marc Abla, who is the executive director of the Illinois Chiropractic Society. And we're going to have a conversation rather than a presentation. People get tired of webinars and, death by PowerPoint and that type of thing. And what we're going to talk about really is a crucial topic for chiropractors, and it's about the potential implications if you're offering discounts to your patients, whether it's your cash patients, your underinsured, your Medicare with limited benefits, or those with extremely high deductibles. What are your options with that? And I'll preface this with, when I talk to doctors, let's face it, nobody likes the idea of offering discounts. And I'll have docs that say, well, I don't want to learn about discounts. I say, well, you're part of Blue Cross, Aetna, and Cigna? They say, well, of course I am. I said, well, doc, you're already offering a discount. The challenge is, how are you doing that with these people that aren't necessarily insured? Because that's where you tend to run into problems, particularly if you've got one foot in that insurance world and one foot in the private pay world. I will tell you right up front that if you are a 100% cash practice, you never bill insurance, you don't see any Medicare patients, you really have very little to worry about. I mean, when it comes to dual fee schedules, improper time of service discounts, that type of thing. I remember years ago, one of my early mentors, Larry Markson, used to say, my fee is my fee is my fee. He didn't believe in offering discounts. Well, managed care comes along and things changed. And we kind of have a new mantra at Chiro Health. It's my fee is my fee is my fee, and nothing is free. Because that's another whole issue these days. And we'll kind of hit on some of that. So, Mark, what doctors don't sometimes realize is there are regulations from our board of examiners, from our provider agreements, our board of the state board, usually the Department of Insurance, or however yours is structured in your state. And then the big one is the OIG. And unfortunately, what tends to happen sometimes is doctors may hear that it's okay in a particular state I'll give you an example. North Carolina says doctors can offer a 30% discount. That's a board ruling. But unfortunately, what a lot of people don't understand, and I have a great respect for the boards, is that the Board of Examiners does not override what your provider agreements, what the OIG says, what your Department of Insurance says. And so, sometimes it's that situation of, geez, whose rules do I follow? And I liken it, right. I don't want to get stabbed or shot, Well, I don't want to get either. So we're going to have a conversation about, time of service discounts, prompt payment discounts, some prepay stuff. Can patients opt out of filing their insurance? So we're just going to kind of go through these one by one. And there is going to be some overlap because there is overlap in the rules and regs. And for those that don't know Mark, if you're listening to this outside of Illinois, he's been at this quite some time, and he has been advising doctors on their billing practices and what they can and can't do, should and shouldn't do, to where they can get paid well if insurance is available, but also still be able to keep care affordable for those patients that may not have the coverage. And let's face it, every patient we see today has limited benefits, whether it's 6, 12, 18 visits. And so at some point, you're going to deal with that issue of even the transition from insurance to private pay. So I appreciate you sharing the documents that you did that were specific to Illinois, and then also kind of recapping some of the federal rules and regulations. So let's just kind of start with what goes on in the state of Illinois, and what do you see as probably the most common thing that doctors are doing wrong with their discounts, specifically in Illinois, and whose rule does it violate?
Wow. So, we go back in history, right? And just if I can do this, hopefully this is all right. One of the things that was really interesting for years, early in my career here at the Illinois Chiropractic Society, when doctors would call and say, hey, I want to offer a discount. This is what I'm doing, or hey, this is what I'm doing. Is that okay? Or whatever the case might be. And it had to do with discounts, waiving copays, deductibles, or whatever the case might be. For years, I had to tell them, really, it's a dangerous game. Your best bet is no. Until a doctor from Mississippi came up to me at a chiro congress, or the Congress of Chiropractic State Associations, where all of the state associations get together and collaborate about how we can do better for our states, came up to me and said, "Hey, this is what I'm doing. Do you want more information?" And that answer was really simple. I love to tell our doctors, yes, it's what they want to hear most of the time, right? So it gave me an opportunity to be able to begin to say yes more often. But in that, the reason why there's challenges with our doctors in providing discounts is a lot of them will just give blanket discounts, right? So they'll say, yeah, for my cash paying patients, I'm just going to give a 30% discount. I'm going to give a 40% discount, or I only charged a fixed amount of money, or whatever the case might be. They'll just come up with what makes sense to them and versus what they're billing to insurance companies, to work comp, to personal injury, or whatever the case might be. And of course, that becomes a problem, because what happens when regulatory agencies, in Illinois, it's IDFPR, or the Illinois Department of Financial and Professional Regulation, when they begin to look at a lot of these things, when there's a complaint, or as they're going through records for another issue, right, they'll look over everything. What they'll do is they'll find a variety of different things that are creating problems, right, for the doctors. And this is one of those areas. And many times it's really hard to escape, because it's in policy, it's in writing, it's on websites, or whatever the case might be. And so proving it isn't difficult, right? It's in marketing. And so those are the types of things that create challenges, right? In Illinois, a lot of it has to do with a couple of different areas. One of them, when we look at the Medical Practice Act, although this is not used frequently, so that full disclosure, this is not used frequently, but it can be used in these types of areas. But it's a provision specific to overbill, and it's a violation of the Medical Practice Act, which is the act that chiropractic physicians in Illinois are licensed under. But it's a prohibited act section, and basically you can't overbill patients. So when we began to look at some of these things, the question comes in: if you're charging a lesser amount to your cash paying patients, a slightly higher amount to your insurance-based patients, health insurance-based, right? Maybe a little bit more to your work comp, and even more than to PI, because that's like winning the lottery, right? And in all of those cases, then become a bit of a problem, because which one is correct? Which one is your fee? And you mentioned earlier, your fee is your fee is your fee. It's funny, I never knew where that came from. I've used that for 20 years, right? I've said your fee is your fee is your fee. Just charge your fee. And at the end of the day, why are you charging more for those other services? And sometimes the argument is, well, it requires more effort, more paperwork, more whatever, but not for the typical disparaging amounts that we see. And have you gone through this study to make the determination, why is there that spread? Why are you charging, what is your justification for that? Where you can actually justify, because you have to, right? Because otherwise, is it overcharging? And that's where the question comes in. Can you justify that difference between what you may accept from a cash patient versus what you may be charging for personal injury? That wide gap.
Yep.
And that becomes a problem.
Yep. Well, and what a lot of doctors don't understand, or we teach about knowing your numbers, knowing what your overhead is. You don't know what your overhead is. How in the world do you decide, what you're going to offer in the way of a discount? And if doctors are giving 30 and 40 and 50% discounts, which they often do off of their PI or workers' comp, you got to ask yourself, do you really have a 50% profit margin? And if you don't, I mean, that's like buying oranges for a dime and selling them for a nickel and wonder why you're not making any money. You can't make that up in volume.
Right.
Again, going back to Larry Markson, he talked about in chiropractic, we have our PI fee, our workers' comp fee, our insurance fee, our cash fee, our mother, father, sister, brother fee, buy 10 visits, get one free fee. And the takeaway from this, docs, is you should have one fee, period. And it applies to everybody in your practice. Secondarily, it should have absolutely nothing to do with what the payer source is. So You have your one fee. Now, does that mean everybody ends up paying the same exact amount? Absolutely not. So if I have my fee at $100, but yet I've got a contract with Blue Cross Blue Shield and they allow 80, they're going to pay 80. If I have it with Aetna and they're going to pay 60, they're going to pay 60. A lot of docs will ask, well, why is it okay for Blue Cross and Aetna to pay us a completely different fee for the exact same service? And the answer is really simple. You have a contractual network agreement. And so we encourage doctors to set your fee, only one fee, and only offer a discount if you're in the health plan, if it's part of a mandated fee schedule like Medicare or Medicaid in some states, or if you have a contractual network agreement, and that certainly can be your Blues, Aetna, Cignas, or the model of the DMPO, the Discount Medical Plan Organization. And the reason you can do that and it's legal with that model is DMPOs are regulated by the Department of Insurance, just like the Blues, the Aetnas, and the Cignas. So the takeaway on offering those multiple fees or having multiple fees like that is to get you to clean up your financial policy and don't go down that road. Here's another thing that we found, Mark. When we asked doctors if personal injury pays $100 for a visit and the doctor thinks, well, my cash patient can afford $50, so I'm going to put my fee at $75, they're doing that to try to accommodate the cash patient. But what are they doing every time they do that? They're leaving revenue on the table. And so when we get them to look at, well, what percentage of your practice is really 100% cash? And it's usually 5 to 7, maybe 10%. So from strictly a business perspective, are you going to structure your fee system to where it is accommodating the minority of your practice? Or should you consider at least looking at your fee schedule, considering your overhead? And, as I tell docs, I don't ever tell doctors you need to raise your fee or you should charge more, but I would challenge you to at least consider charging at least what the insurance companies think you're worth. And in internal surveys that we've done, no kidding, in the state of Texas, we did a survey of about 50 some odd clinics, and over almost 90% of them were not even charging what workers' comp and personal injury allowed, leaving revenue on the table every time. So the multiple fee schedule, dual fee schedules, as they call them, some of them we have triple fee schedules, and like I said, the mother, father, son, other plans, and docs, you just need to move away from that.
No, and I think that I'm going to use a different word than what I think you've used. And when we start talking about these widely varying reimbursement schedule or fee schedules, right? Not reimbursement, fee schedules, right? When you have those big of swings between those types of things, and I talked about that justification. A lot of times what happens is, well, I do that because that's what they will pay, right? I do it because I can get paid more. And ultimately, when we start to look at that, I will tell you, as you have that conversation, you start getting dangerously close to the textbook definition of healthcare fraud.
Yep.
And that is one of the biggest dangers with these multiple fee schedules. Again, not to be confused with insurance companies, right? Not to be confused with network agreements, as you mentioned earlier, or contractual amounts that are established with state registered organizations like your Blue Crosses, like correctly registered discount medical plan organizations, like your Aetna, Cignas, whoever else you want to throw in there that are actually registered with your Department of Insurance. At least that's the way it is in Illinois. They have to be registered, right? And close that loop. I'm talking about having those varying fee schedules within your practice. And that's a problem because insurance companies don't like it, and they actually have a history of not liking it.
There are a number of court cases. One that comes to mind is Kennedy versus Cigna. Kennedy was a chiropractor, and in that particular case, I think he was waiving some copays and that type of thing. And a lot of doctors don't realize is that copayment or deductible is a contractual agreement between the insurance company and the patient. And in this particular court case, Cigna, basically held that if the patient is relieved of any part of their responsibility, it completely relieves the payer from their responsibility of paying. And they won that. Court case. So You know, you just got to be careful with that. Again, to me, the takeaway is I have one fee. I charge the same to everybody. The only time I offer a discount if it's part of the contractual network discount. And I want to back up for a second. When you were talking about charging more to the insurance, it's the language in Medicare is, yeah, we've always thrown around that term, most favored nation. I have searched and searched and searched on all the Medicare stuff, and there is no term related to Medicare called most favored nation. What it says is you can't charge Medicare substantially in excess. Well, the OIG was going at one point to define what a substantially in excess meant, and they realized that if they did that, everybody's going to go right up to the edge of it. And so what they decided to do is they declined to define it, and they said, we will look at it on a case-by-case basis.
Yeah.
So there's your crapshoot, Doc. You know, it's
Yeah.
like, you're dealing with OIG, how lucky do you feel?
That's right. You know, I want to throw one in and just to kind of play a little bit more. I think you talked about the waiving of copays and deductibles and that and that type of thing. And that is a form of discount. And I think it's really important to touch on this. If you're wondering, there's a federal case out of Hawaii, and it's with a dentist actually. And here's what makes that one really interesting. It's where a dentist was waiving about 30% coinsurance. So they had their patients that had coinsurance of 30%. They would just waive it. But then, of course, what they submitted to the insurer was their normal office fee. So just to use our round numbers, again, we're not talking about exact figures or telling our doctors what to charge. We don't do that. But it's $100. He'd waive the $30 coinsurance portion, but he would still bill the insurance company for the full amount. We know that that happens in our world, and it shouldn't, by the way. But on that federal case, what the court came back with, and again, it's pertinent because this is a federal case, right? The court came back and said, well, you can't do that, knowing full well at the front end that you're only going to collect that lesser amount in this case because you're waiving it, not because you want to collect the full amount. So we're talking about, this is different than billing your fee is your fee is your fee. This is when you're talking about post-network reductions, right? And you bill that lesser amount that doesn't include, or you bill that full amount, knowing full well that you're going to waive those. What the court said is, here's the example, and you should have just billed that lesser amount. You should not have billed the full amount. And ultimately, in this particular case, the insurance company won. And that's a really important thing to note, because when we start talking about waiving copays and deductibles, let alone you're leaving money on the table, just being blunt, you're providing services at a lesser value than what even the insurance companies indicate. And often I hear our doctors say, well, you know, my patients can't afford it. But that's a whole different question, right? We can talk about financial hardship, but at the end of the day, doctors, if I can tell you one thing I've said again and again and again over the last 20 years, you provide a good and valuable service, you deserve to be paid for it. And too often we think that we have to err on the side of our patients, and we love our patients. And I think it's the thing I love about this profession is how much our doctors love their patients. But sometimes you love your patients so much that you put your family's livelihood, your livelihood at risk. And there's just no need for that. You know, we should be collecting what is due, right? We should be charging what is reasonable. That's why you have a fee schedule. So follow it. But in this case, really good example where the courts are saying you can't collect that additional amount. You waived it. So now the ultimate amount, they backtracked and had that recoupment take place where they could take back that differential. And those things matter.
Yeah, and the problem is it isn't just that they're going to be able to legally pay you less. That is textbook insurance fraud. And so all of the fines and the penalties, I mean, they can go into, and you know, you see these horror cases of this doctor got fined $150,000, $200,000. Well, doc, it wasn't because they got paid that much. It was because what they were doing violated a federal rule and regulation, and oftentimes those are what they call per line violations. So if you build out 5 services on 10 different claim forms, that's 50 violations. And if they're really trying to make an example of somebody, I mean, you're talking about, if you're talking about a Medicare reimbursement of less than $40, but you could potentially be on the hook for $200,000 in fine. It's like, just don't do it. I want to touch on one other thing. A lot of times, prompt payment or time of service discounts are used interchangeably. And some docs think, well, I'm given a 30% time of service discount, but I don't have to bill the patient or the insurance company so I can give a discount. Here's the issue with time of service discounts. A true time of service discount has got to be defensible, meaning it needs to be comparable to what it actually costs you to do billing. And this isn't my opinion. You go search it on Dr. Google. The average billing cost in a chiropractic practice or medical practice is about 5 to 7%. So if you are giving 15, 20, 30% discounts, that is not defensible. It's really just, let's face it, it's smoke and mirrors calling it a time of service when it truly is a dual fee schedule. So, make sure that your prompt pay discounts are reflective of your billing costs. Do something to document what your billing costs are in case it ever becomes an issue for you.
So now, can I follow up on that just real quickly?
This is a conversation.
I think that you make a really, really important point here, and why we even have our doctors pause on percentages, right? Because then the question becomes, outside of you outsourced your billing, which, can happen. And then it's more easily definable of exactly what your costs are related to insurance billing. But when you're not outsourcing, the question is, how much is it really costing you? And can you do it on a percentage? So maybe you're just doing an adjustment one day, right? And how much more does it cost you to file that insurance on that first visit, where you're billing an exam, maybe an x-ray, possibly the adjustment, and maybe even an additional therapeutic modality, right? When you're looking at that full suite of services, that may be the whole thing, right? And you give a percentage. Can you justify that insurance claim actually costs you that much more, right? So that's what a percentage does. And many times, really, the percentage probably isn't correctly reflective of that cost. And if you can't justify it, then we're getting, again, dangerously close on those discounts to having a problem where a federal court could say, no, you actually overbilled your other insurers, right? You overbilled PI, you overbilled work comp because of what you've demonstrated over time and what you can actually justify as your actual costs for filing those claims and waiting for payment. So all of that really needs to come into play. You need to take time to do your analysis, I guess is probably a good way to put it. And we're not completely comfortable. I'm not completely comfortable just saying that a carte blanche percentage is going to be fully appropriate.
Yeah, that range of that 5 to 15% came from an OIG opinion from years ago that was for a specific hospital that made the inquiry to OIG about could they offer some type of prompt payment discount, and they outlined the specifics of it. And while it technically was an issue, they came back and said they didn't think that the issue would rise to the level of creating an investigation because of some of the caveats that they required. Number one,
that's important. The details in that case matter. Yeah.
You cannot advertise it. In their situation, it could only be discussed and offered at the time of discharge. Well, let's face it, we don't admit patients practice. Anyway, had 4 or 5 components there that's the only way we could do that. And unfortunately, what many of our docs do is they just offer it right out of the gate. And the other thing you have to realize with OIG opinions, and we've even said this in the past, while that case does not apply to chiropractic, typically rulings by the OIG give the healthcare industry what's called some broad guidance. But the reality is, don't rely on that 100% because it is just like they said previously, they're going to look at it on a case-by-case basis. And if they can substantiate that you're offering those discounts and you're charging more to in that case, Medicare, it is absolutely a problem. I want to touch on one other thing, Mark. After doing this for 16 years now, I can tell you that it is a rarity that a doctor ever gets audited or investigated because of what he's doing with his discounts. Now, that sounds really strange.
Right.
In this conversation, what happens, doctors, is they may trigger an audit for a completely different reason. Maybe you're seeing more, maybe you have more 98940s than anybody else in your area. So you're an outlier in some shape, form, or fashion. And then when they realize you're an outlier and they start looking at specifics, that's when they find it. And so the point is, you can say, well, I don't know anybody that's got caught for that. I don't know anybody that's had any problems with that. It's usually because, number one, it wasn't directly related to that. It was a finding during the investigation. And here's how it works. If an insurance company or an investigator knows that Ray is doing something wrong, he's going to assume you're doing other things wrong, and they're going to look deeper and deeper and deeper. And if you're blatantly doing it wrong, like I said, you're advertising stuff you shouldn't, they're going to make an example of you. And so I liken it to the person who is, and I tell people I've gotten driving awards all the time. Some people call them tickets. But if I'm speeding down the road and I get stopped, I may get a ticket for speeding. But if I've got a radar detector, then that's, as I say, that's just going to piss off the popo. So he's not only going to write me a ticket for speeding, he's going to ask my registration, he's going to write up my tail light, he's going to look at my expired taxes, they're going to make an example of me because what is a radar detector? Knowingly and willfully violating the law. And so if you are waiving deductibles, waiving copays, you got these dual fee schedules, guess what you're doing, Doc? If you know what the rules and regs are, and you can't not know them, your healthcare practice these days, right? And even if you don't know them, you're responsible for knowing them. So you just got to understand that while you may not hear of doctors actually getting directly in trouble because of fees, unless they're off, advertising improperly, then you'll get reported by your colleagues. Let's face it, that's how it happens. That it really comes as a secondary effect of other audits and investigations. So
let me add something to that, if you don't mind. I think it's really important. Doctors have no issues sharing when they don't get caught. And I'm just being honest. I have watched this happen too often, where you have no issues talking about hey, I was able to get here in record time today because I was doing 85 in a 70 or whatever the case might be, right? But when you get that ticket, maybe you're not quite as quick to share, right? And what we have found is a lot of times our doctors who end up having disciplines against their license here in Illinois, and they're not going to jump out and just share all of that information. They're just not going to do it. They don't want their colleagues to know. There is a form of embarrassment there. So you may never know. They may just suddenly stop waiving their copays and deductibles. They may stop advertising that they give cash discounts. They may stop these other things, and you may think, oh, they finally saw the light. They may have had help. They're just not going to share it with you. And so these aren't always broadcast. I think we think of sometimes the huge stories that are out there. We forget that most of these stories happen. I mean, yes, it's public, but you have to go dig for it. They're not going to get a big news splash for what has gone on.
Interestingly enough, in a lot of states, and you're spot on. I mean, let's face it, if I get audited, well, for those that don't know, the reason I got involved with the discount medical plan is I got reported to my state attorney general. For what? Charging more to an insurance company than I did to a cash patient. Now, fortunately, it wasn't against the law in my state at that time. But the reality is, whether it's against the law or not, how does that really look in the eye of a patient? It just doesn't look good. And so that's what made me start looking at, well, why can Blue Cross and Cigna, that's a new word for me. I might coin that one. How is it that, they can pay us these different fees for the same service? And the reality is I was able to find that these DMPOs are what allows us to do that under the contractual network discount. And anybody that's involved in compliance, like our company, and we have some of the best speakers in the profession that we sponsor, and I'll bet you almost every one of them get calls every single week of somebody that's in trouble. And let's face it, you have one of those issues and you want to make it go as quietly and quickly as you can. And, we like I said, we have some experts that represent doctors when things like that happen. So if you get into an issue, contact Mark, contact us. There's quite a stable of people out there that deal with this all the time. And again, you can't promise you can make it go away, but I think, and I'll just give you a prime example. you see these horrible cases, $2.5 million. You're seeing that a lot now with these neurostimulators and things in chiropractic. Unfortunately, something as simple as not charging for muscle stem to a Medicare patient because you're a nice guy, or you say, well, I don't charge muscle stem to anybody because insurance doesn't pay it. Well, you're a nice guy, but you just created an inducement. And we know for a fact there's doctors, one particular in Illinois, that they negotiated the fine down to about $80,000. So you heard that saying, no good deed goes unpunished. There's the my fee is my fee is my fee, and nothing is free. So be careful when you're putting together treatments for patients that you are documenting everything you did and billing for it, and you can't hide behind, well, I don't charge anybody for that. It's still considered an inducement, as that case was.
If it has value, right? If it has value, then you cannot do those. You cannot offer those for free in those instances.
Right. Okay, Mark, let's take a quick break to hear a word from our sponsor.
You bring up this, you bring up OIG and we talk about gifts and inducements. Can I touch on that? Because I think that's really important. I don't know about other states. I don't know how they loop these things in, but we have very specific cases in Illinois that have actually come through with licensed discipline, where we'll have a doctor who is offering discounts, right? And they do not have the exclusion, right? If they're not properly done, like cash discounts or offering, discounts or free services or whatever the case, or coupons, we'll use that as an example as well. Any of those types of things. And they're not giving the exclusion for Medicare, Medicaid, Champus, and every and other federally funded programs, whatever the language that you should use. That's pretty close. But if it doesn't have that exclusion language attached to those discounts, as an example, in Illinois, they actually ended up with a discipline on their license because it was considered to be false advertising.
Wow.
Because it's not legal to do, right? So they can't legally offer that to Medicare patients. By offering it very broadly, not having the exclusion language in order to fit within the confines of what OIG considers to be a gift and inducement, Illinois said that's illegal, right? So although you're not violating state law, you are violating state law from an advertising perspective. And we had a number of doctors who ended up having disciplines on their license because they were not following statute, because they were actually giving those discounts to the Medicare patients as well. So it's, in those cases, it's not even a broken tail light, right? In those cases, it becomes the impetus for the action by the state regulatory agencies.
I've had a lot of doctors over the years say, well, I don't take care of Medicare patients, so I don't have to worry about, those issues of anti-kickback and inducement. And unfortunately, let's face it, we're trained as chiropractors, we're not trained as compliance people. And what a lot of folks don't understand is the vast majority of the states have anti-kickback and anti-inducement rules and regulations that mirror the feds. And in fact, if your state mirrors the federal regulations and the feds trigger an investigation, your state can get part of that revenue because you're following the federal guidelines. So there's a huge incentive for the states to follow the federal rules and regulations, because the OIG, when those regulations were put into place for anti-kickback and anti-inducement, the reason that is in place is to protect the financial integrity of the Medicare program, because they don't want people doing things that are going to drive up the cost. Well, the state rules and regulations on anti-kickback inducement are for the same reason, but not for Medicare. They're to protect the financial integrity of the health plans. So even if you don't see a Medicare patient, don't think that you are exempt from anti-kickback, anti-inducement regulations. And that really, the anti-kickback and anti-inducement are two regulations that they often compound. Like if I waive a deductible, it's not just a waiver of a deductible. It's a waiver of deductible, but it's an anti-kickback violation, and it's considered an inducement. So again, that's where they kind of pile on with these multiple layers of penalties.
Yeah, exactly.
the next thing I want to talk about, Mark, is and I'm sure you see this as well. Care plans are a big thing these days, and we see and have seen over the years. And regardless of how you feel about care plans, what we have unfortunately seen is, let's say a doctor puts together a care plan for 30, pick a number, 30 visits, and let's say it cost, and I'll just use round numbers. Let's say it costs $5,000. The doctor will offer that care plan to a patient, and if they'll pay for it up front, they'll give them like a 25 or a 30% discount. Sounds reasonable. But unfortunately, if those patients are insured, like let's say Blue Cross covers your first 10 visits, and they're bundling that together and offering a discount, what has happened is the courts have said, you are actually discounting by whatever percent the deductible and copay. You're in violation of your provider agreement, and you're in violation of anti-kickback and anti-inducement. So our advice, I don't know what your advice has been, but if you choose to do that, make sure that if you're offering a discount on that type of package or that type of plan, that the discount only applies to the non-covered services. You always collect the deductible. You always collect the copay. You should not discount any part of that, because not only is it a violation of the contractual agreement between you and the network, but also between the patient and the insurance company. And they do have a contractual obligation to pay those amounts. I don't know if
it goes back even to to that Hawaii case that we talked, that federal case in Hawaii that we discussed earlier, where the courts ultimately said, no, you're discounting. You should have discounted the entire bill. In fact, it's one of the challenges that we see even in those network contracts and where some of those discounts are offered in general. What the general concept is here, we've seen in the courts here as well, is ultimately that discount time of service needs to be offered in general to the insurer as well. As odd as that sounds, so you have to give the insurer that opportunity to be able to pay on the same date of service as well, which then potentially creates some additional challenges in regards to your contract and what you've signed, right? So it's a really interesting, it is a quagmire. And between the Medical Practice Act, other statutes, your anti-kickback statutes here in Illinois, the references to the federal statutes and everything else. In Illinois, it's a quagmire because we don't have, the state, I think you mentioned North Carolina earlier, that says you can, that their board has said, that a reasonable discount for time of service is X%. Now, you still have all of the other considerations, network agreements, federal law, things like that are still going to rule in those cases. But in Illinois, we have some lighthouses, right? So we have some things that can help keep us away from the edge, but there's no clear statute that says this amount is okay, right? And that's what makes it so complicated in Illinois, unless you actually have a mechanism to close. I call it a legal triangle. And you made reference to this really early in our conversation, where you've got a network, if you will. You've got an insurance company, a network, whatever you want to call them. And they're actually registered with the Department of Insurance, right? So they're one entity. They have a contract with a patient for, in their plan. They also have a contract with you. And then you have a contract with the patient when the patient shows up in your practice, right? So you have this nice little neat triangle. But when that triangle gets broken, right, when you remove one of those pieces is when the wheels begin to come off from a legal standpoint on that discount. And why it creates some of the challenges unless you reclose that legal triangle. And what we tell our doctors is we don't officially endorse any specific organization, any specific discount medical plan organization, but those that are in the chiropractic space, we're only aware of one that has gone through that process of really being registered appropriately with our Department of Insurance in Illinois. You may or may not.
No, because you call me when we don't file on time, or there's some delay by your Department of Insurance.
And that's exactly right. Which didn't happen, right? They delayed, and I let you know, hey, just so you know, this hasn't happened. But that's what actually closes what I call that legal triangle that helps our doctors be able to do that appropriately.
So we were talking earlier. I want to go back to this for a moment when we were discussing, well, what really triggers these types of fines and penalties, and is the primary reason due to the fees, and how does an insurance company find out about what your billing practices might be? And I'm going to tell you the simplest way they can do it. And you may have seen this form before. We use it in most of our classes. It's actually a simple records request. We get them all the time. But the records request, and this one happened to be from Aetna, it asks for, a copy of the medical records, a copy of the billings, asks for the billing statements, but it goes on and asks, all the things that would be necessary for what would be considered utilization review and establishing medical necessity. But on the second page of it, guess what it asks? It says, do you offer your patients any time of service or discounts on their deductibles or copays? And of course, if you're smart or you're not doing it, you should say no. But what happens sometimes is we may have Sally Sunshine filling out our records request from the insurance company. And what does she do? She thinks, well, Doc has been seeing Miss Jones forever, and he does give her a discount. And there's Miss Susie's been with him for 20 years. And so they think about the exception rather than the rule. And you check yes to that, and you would just went from the stack of, hey, they know what they're doing, to we have a problem. And then the other question is, so they're asking questions about your billing practices. Well, what does that have to do with utilization review and medical necessity? Absolutely nothing. So when you're looking at, what's your risk and how are these things found out, it literally can be something as simple as a medical records request. And I will tell you what, when I saw this in our practice years ago, I started making it my practice. I look at those requests. I want to know what's being asked and how they're being answered. And, there's one thing to delegate your responsibility, is something else to abdicate it. And Doc, if you aren't looking at what's going out of your office, you could be inadvertently putting yourself at risk. Nobody intentionally doing it, but you got to be careful how you answer. And so for those that do choose to use a model like a DMPO, you get that kind of question, and it's real simple. Say, the only time we offer a discount is when it's part of a contractual network agreement, if we're in their health plan, if it's a mandated fee schedule, or if they're part of a discount medical plan. And what do they do when they get that one in? These people know what they're doing, and they leave you alone. Big change.
Yeah. I want to add something to that. I mean, yeah, you're right. It's as simple as a records request. But one of the things that we tell our doctors all the time is this. Where's the number one source for complaints? It's employees. It's staff. And at the end of the day, this is really important to remember. And I think, sometimes we'll have this conversation and the doctor at the other end will say, well, Mark, Betty or George has been with me for 35 years. There's no issues here whatsoever. In the last month, because I can say it right now, in the last month, I got a phone call from one of our longstanding members who has had a staff member that's been with them for the time that they've been open, 35 years. And they had a not amicable separation, unexpected, no details needed, right? 35 years of employment. And the separation body somewhere, right? And just a thought, this means that Betty or George, that staff member, had 35 years of institutional knowledge. And, there is that pesky little thing called, I think it's KETAM, right? So KETAM basically is that it is where the whistleblower actually can receive a portion of any kind of civil monetary penalties that are involved in any violations like this, right? So when the penalties come down, in the last I looked, and this isn't scare tactic, it's just the reality. So don't be scared by this. Just, I want you to understand it's not, you can't sit back and say, this is never going to happen, right? But the truth and reality is, what the OIG says for each violation of their gifts and inducements, what are the fines up to? It's $10,000, right? $10,000 per incident. And how many patients have you given your discount to without giving that qualifier, without all of these little facets being covered, without your I's being dotted and your T's being crossed? And again, I think so often we think we're just safe. At the end of the day, guess what? We have to be a bit more open to the fact that instead it's so much easier just to be compliant than it is to just feel like we want to be safe because we have employees that have been here for 35 years, or our patients always love us. We've never had any issues with billing with our patients.
Right up until
You're saying that, then I think you're maybe gravely mistaken or just not in communication with some of your patients, because the best doctors on the planet will have billing challenges with patients occasionally. So,
I've often said you can save a patient from back surgery, but you let their bill be off by 50 cents and you go from hero to heathen. I mean, it happens.
can happen. Absolutely.
What a lot of, we have relationships with, some of the major malpractice carriers in our profession. And I had the opportunity to sit and talk with them, and I just asked them, what's probably one of the most common reasons that lawsuits are filed. And guess what, docs? It is not over your clinical care. It's over dollars and cents. And like I was saying, if the billing is off or you don't resolve an issue with a patient and you ignore it, then that is one of the most common reasons there's a frivolous lawsuit. But once it's filed and it's on record, that's the foot in the door. Because not only can your board investigate it, but I've sat in hours and hours of our board meetings, and I'm just going to give this as an example. There was a doc here who was doing these prepay plans for neuropathy, whatever, forget what it was for. But long story, no, this one would happen to be for weight loss. And he had a patient who came in for weight loss, filled out her intake form. There was nothing on there whatsoever about back pain or neuromusculoskeletal pain. She had Blue Cross Blue Shield. Any good chiropractor can find a subluxation or joint dysfunction on a patient. So as part of his exam, he found problems and he documented it and he billed insurance for those services. Fast forward, the patient dropped out of the care plan, requested a refund. He had all the right contracts, had his I's dotted, has his T's crossed, and tried to go back and bill the patient for his actual fees rather than extending the discount. And so he pissed off the wrong lady, ends up in a board investigation. I was there 13 hours one day listening to all of this. And guess who else was in the room? Blue Cross, the state attorney general, our attorney general for our state. And guess one of the outcomes from that was treating patients for weight loss as a chiropractor is not in our scope of practice. And so number one, the patient didn't have a complaint about back pain. And so all of that sudden that turned into billing fraud and Blue Cross asking for more records. And this might surprise doctors, but guess who Blue Cross auditors know? Aetna auditors and Cigna auditors and OIG auditors. And so it's kind of like once you're on that radar, it's Katie bar the door. And so our whole point in this, Mark, I'm like you. I never want doctors to be in fear. I do want them to be informed and then just figure out it is so simple to solve the problem. And we have people that expend tremendous amounts of injury. Well, how can I get around that? How do I avoid that? How can I do this? And so I don't ever like to just tell people what they can't do. I like to tell them what they can do. And there are ways to deal with these issues and be able to help those patients. Again, the key is making sure that you're doing it the right way.
Yeah. And it's, Doc, it's really important also to understand that, again, when it comes down to this fear thing, it's not a matter that these are really simple fixes. They're not complicated fixes when we're talking about these types of things, right? There's ways to make this happen. But at the end of the day, years ago, I had a call from a member, and it was on a simple change in his practice, just a small procedural change, actually having to do with the AVN form. So related to discounts. But he tells me, he says, Mark, look, I'm not going to make that change. And I mean, the change was so minuscule. He goes, I'm not going to make that change. I prescribed the philosophy that things aren't as bad as they seem. And the unfortunate reality is, sitting in this chair, I get the phone calls from doctors where it is worse than it seems, right? And so this isn't from a fear factor, right? And that's not why we're having the conversation. This is such a simple fix. It's an easy thing to repair. It's an easy thing to employ or deploy in your practice. This is a change that needs to happen. in order to make sure you can dot this simple I and cross this simple T. Don't sit back and just say, I'm not too terribly worried about it. Too many things can go awry, and you have too many problems and challenges as a result. There's no need for it.
Yep. The making changes in an office is hard to do. I mean, change is hard for everyone, and it's really, really interesting. When we've had doctors that come on board with us, they'll start it for a little while, and there may be some pushback from a front desk or something because it's just different. That's what wasn't what they started with, and so they know they have an issue. But and I'll draw the analogy. Unfortunately, it's like people who are in an abusive relationship. What's the likelihood they leave one and go into another? And you think, why would you ever do that? Because change is hard. And while that's a drastic maybe comparison, the reality is a lot of people just think, well, I've done it this way for 20 years. It's no big deal. I don't need to make a change, or it's gonna require some change. And change is inevitable. I mean, you have to do it. And because there are risks involved with not changing, just taking some simple steps, literally, you can clean. If you would like to not worry about improper time of service discounts, inducement, anti-kickback, dual fee schedules, it's really simple. Use that. I'll be happy to share that form with you. It's BJ Palmer's financial policy. We put it together as a sample. It basically, tells patients we have one fee. It applies to everybody. The only ones that are given a discount is if I'm in your health plan, part of a DMPO, part of it if it's, part of a DMPO, or if it's a mandated fee schedule. And it's very clear and clean cut. And if they're not on that list, you don't offer the discount. And that's the way you keep your practice compliant. So you literally can make that go away. So, I do want to speak to the legalities of the discount medical plan model. They are regulated in most of the states, and clearly, any company, particularly in not just in chiropractic, but everywhere, everybody's got competition, and we have competition. There are some others that have started up, and as I tell docs, if you don't use us, at least use someone. But I will also ask you to do your homework. Check your Department of Insurance, check with your state association, see if they are approved. Unfortunately, there are some models out there that from our internal review and from our healthcare attorneys could be problematic. I can't tell you we have an OIG opinion that they are, but there are some models where patients are given free things like a free membership or free this or free that to be part of a group. And if you understand inducement rules and regulations, the anti-kickback and the OIG opinion, 2009 opinion on gifts and inducements says that you can't give away anything more than $15 in value or a total of $75 in a year. But if you do, it's an inducement. So I just want you to think through the process. If I happen to give you this pin for free, and as a result of that, you're getting 25 and 30% discounts, that's where the value is. The difference in that model and a DMPO model like we run is the patients actually pay a fee, $49 for the year, covers them and their family, and that's what entitles them to the discount. And it is that contractual network agreement between us, the patient, and the provider that makes that legal. I have concerns, again, strictly from an inducement perspective, that if I'm giving you something for free and the end result is you are getting something for free or at a substantial discount, run that by your attorney, make sure it's okay. There's nothing more frustrating, I think, than thinking you're taking a right step to try to help your practice and your patients, and you find out you have a warm, fuzzy feeling for no apparent reason. And so, and again, competition is not an issue, but I expect everyone to be held to the same standard. And quite frankly, we feel like we have an obligation to this profession that if they're going to use this type of model to, as the saying goes, buyer beware. So anyway, do your homework, know the rules and regulations. Mark, I'm going to, some of the material you sent me, I'm going to ask you to to share with me and also share with the docs that might listen to this. You kind of had a 7-point outline general principles regarding discounts and private carrier. And then you had an article that you did, discounts, but the guy down the street's doing it, which I thought was really, really good. So if we could make those available, and then for those who would like a copy of that one-page simple financial policy, shoot me an email at drfoxworth@gmail.com. That's DRFOX, WORTH @gmail, and I'll make sure we get that out to you. Anything else you want to share with the docs, Mark?
I think you've nailed it. And thank you for making our doctors aware of this. And we started this before we started recording. I think I mentioned it to you, but this is really important. It's funny because we had a long-standing member, very long-standing member, key stakeholder in our organization, call me actually this morning on this exact issue and saying, "Hey, I've been just giving discounts. What am I doing wrong?" And we walked through a lot of what you and I have talked about. We walked through all of those legalities. And I told him what to watch out for, what to investigate in regards to when making a decision for a discount medical plan organization at the MPO. They're going to make sure, the biggest thing, if nothing else, make sure that they are actually properly registered with the Department of Insurance here in Illinois. That's mission critical. And that should be the first step in that conversation. If they're not, walk away. Because in those particular cases, you're not completing that legal triangle. But this continues to be an issue, whether you're a new doctor or a doctor that has been in practice for 40 years. These continue to be issues. You want to make sure that your legacy that you leave and the practice that you're building today is compliant, because you want to keep your money. Let's be honest, you provide a good and valuable service. You deserve to be paid for it. Quite candidly, you deserve to keep it. And we want that. We want our doctors to be wildly successful. We want them to be wildly successful in when they're treating their patients. And then we don't want them to have to be concerned about a lot of these things. And we want them to be able to be compliant in all of these areas and have the appropriate tools to get it done. So for us, that matters. Yeah, we'll definitely share the article and provide that for you. I think, I believe it's great information. It's a lot in one small package, but it does give you some of those. I think you pointed out the seven key things that they need to know in regards to any kind of network agreement or provider agreements to sign with insurance companies. So no problem.
Mark, I had made myself a note, and I think it is important to go back to it when we talk about that change thing and how we're running our offices. One of the things that I share with docs from the stage is, of all the patients that we see, my office was 2 blocks from Blue Cross Blue Shield. So you can doggone well bet I saw auditors and investigators and we're in close to downtown Jackson. So those people are around. And the reality is you don't know who people are when they come into your practice. And what I tell docs is, if you looked at your list of new patients for tomorrow and there was anything, whether it's your documentation, your billing, your collections, if there was anything that you would think, oh man, I need to change that, I'm getting ready to see an auditor, go ahead and do it now, because you don't know that they haven't been in. And the reality is, you get something like this that is negative to you and something you've got to struggle through, it's life-changing. And I don't mean in a good way. This is horrible. I have 2 friends that I've lost over the years who went through audits and decided it wasn't worth it and left the earth. And the reality is they could have cleaned it up so easily. And that's a drastic example. But it is not just about the dollars and cents. It is about your legacy. It is about your future. It is about preserving, the wealth for your family. And it's just not worth the risk to do it the wrong way. So if anybody, like I mentioned earlier, ChiroSphere is not for everyone. There are some folks that don't need us at all. We offer what's considered a free consult call to find out if you need us. And if so, we'll help you with what we call a profitable discount strategy. I never believe that you can discount your way to success, but I do believe that you can arrange your financial policy in such a fashion that if you are offering discounts, you're still remaining compliant and still remaining profitable. And I think that's the key takeaway. So reach out to us at ChiroSphere.com. That's our website. Or I think the number is 888-719-9990. I don't call myself often, but I think that's the number, Mark. Thanks so much for your time, buddy. And I'll get to see you in a couple of weeks in Denver.
Yeah, we'll see you then. Looking forward to it.
All right, buddy. Take care. Thanks, everybody.